Good day, and dear students, we want to present you a case study about liver failure, and we hope that it will help you to understand this topic deeper and to apply it in your clinical life. A 50-year-old male has had weight loss and reduced appetite for past 6 months, and for 1 month he has had swelling of his lower extremities and enlargement of his abdomen. He takes no medication, but he drinks a lot. Here a pure alcohol amount is given. He has been a chef in the fashionable restaurants, and he now lives alone as his wife left him 1 year ago. As you see, despite weight loss, he has increased size of his abdomen, and together with information about swelling of his ankles, it may help us to think that maybe there is fluid accumulation in the abdominal cavity. Physical examination. Patient has conjunctival icterus, he has jaundice, he has pitting edema of his ankles, hypertrophy to muscles of his limbs, and on upper chest some spider angiomata are revealed. His pulse is normal, heart rate 92 per minute, blood pressure is normal, and there are no other problems, no problems in cardiovascular and respiratory system. His abdomen is distended. We can see distended veins on the anterior abdominal wall. They create symptom of caput medusa in periumbilical region. We can see umbilical herniation here. On percussion, dullness on flanks was revealed, and this is shifting dullness. When patient changes his position, dullness is shifted to the lower part of abdomen, and there is positive fluid wave test. It means that there is free fluid in the abdomen, ascites. Ultrasound showed moderate ascites, a slight reduction in liver size, and liver surface is nodular. These two are typical for advanced liver fibrosis, liver cirrhosis, and patient has splenomegaly. His portal and splenic veins are dilated. Here we have a lot of symptoms, so let's combine them by pathogenesis. Some symptoms are related to hyperestrogenism. If patient has liver failure, his liver can't destroy now estrogens, they are accumulated, and they may cause symptoms related to vasodilation like palmar erythema and spider angiomata, dilation of small vessels. Also, patient may have gynecomastia and testicular atrophy. Some symptoms are related to portal hypertension. This is ascites, splenomegaly, portosystemic shunts on abdominal anterior wall. Some of these shunts are not visible, but are very important because of the risk of bleeding from these veins. These are lower esophageal varices and hemorrhoidal varices. Blood test. Let's start from liver enzymes, discussion of AST and ALT. Both are elevated, but AST prevails. It means that patient has cytolysis. Elevation is mild, and ratio AST to ALT, the Ritis ratio, is equal to 2. Later, we discuss why. Next to enzymes are enzymes of cholestasis. Alkaline phosphatase, we have very small elevation, and vice versa, we have prominent elevation of GGT. It means that we may exclude cholestasis because alkaline phosphatase is normal, but now we must explain why GGT is elevated. Gamma-glutamyl transferase is an enzyme which is involved in the metabolism of glutathione, and because glutathione is antioxidant and helps to neutralize and eliminate many toxic substances, alcohol activates gene of this enzyme, and this is why enzyme is elevated in the blood, especially because alcohol also increases membrane permeability. So let's exclude cholestasis, cytolysis, yes. Now let's assess synthetic function of liver. Patient has low albumin level, low total protein level, and prolongation of PT, prothrombin time. Because liver produces almost all blood plasma proteins, when there is liver failure, synthetic function suffers, and it leads to, at first, prolongation of prothrombin time, because clotting factor, 7th clotting factor, has the shortest lifespan, half lifespan is 4 to 5, 6 hours. Albumins live longer. Their half lifespan is approximately 20-25 days. And so if we have acute liver failure, we pay attention to prothrombin time. It is much more sensitive test. Albumin level will suffer later if it is chronic failure, like in our patient. Patient has also elevation of bilirubin due to direct fraction, conjugated hyperbilirubinemia. This is why he has jaundice. And because bilirubin is elevated due to direct or conjugated fraction, we may exclude hemolysis and Gilbert or Gilbert syndrome. And because we see no signs of cholestasis, we may think now we may attribute the high bilirubin to problems with hepatocytes. Hemoglobin is decreased, patient has anemia, and this may be due to enlargement of the spleen and excessive sequestration of blood cells there, but through this mechanism we can't explain why MCV is elevated. And so now we must think that patient probably has folic acid deficiency, which is quite probable in case of alcoholism, and maybe also B12 deficiency. WBC level is normal, but there is thrombocytopenia, which may be due to splenomegaly, but also let's recall that thrombopoietin is produced by liver. Erythropoietin is produced by kidneys, but thrombopoietin is produced by liver, and in case of liver failure, thrombopoietin production is suppressed. Patient has hyponatremia. Later we explain probable mechanisms. Potassium level is normal, urea is decreased. because urea is produced by liver through ornithine cycle, and this is very important to neutralize ammonia. It means that if we say low urea, we may think that ammonia is elevated in the blood. And creatinine level is elevated. No, creatinine level is normal, so we don't have problems with kidneys. Okay. Now about hepatic acinus structure and how it is related to blood test of our patient. Hepatic acinus is a functional unit of the liver, and there are 3 zones in hepatic acinus. Zone 1 is neoportal triad. This zone has better oxygen supply. Hepatocytes of this zone have more ALT than AST. In zone 3, which is located near central veins, we have low oxygen and high level of cytochrome P450. This is why if there is hypoxic injury, maybe hypoperfusion in shock, there is injury to zone 3. And if there is toxic injury, also zone 3 will suffer. Pay attention that in zone 3, AST is expressed more than ALT. Why a toxic injury may cause injury of zone 3? Because many xenobiotics are metabolized by cytochrome P450, and sometimes toxic intermediate metabolites are produced, and they can injure zone 3 hepatocytes. Now, practical part. If there is toxic injury or hypoxic injury, AST prevails, and their Ritis ratio, AST-ALT ratio, is 2 or higher. In case of acute viral hepatitis and autoimmune hepatitis, because predominantly zone 1 hepatocytes are affected, ALT is more than AST, and so ratio is less than 1. In case of alcohol abuse, we have toxic injury to hepatocytes. It means mostly AST will be elevated. And about level of transaminases, which also have important diagnostic value. If we have acute massive injury to hepatocytes, like in acute viral hepatitis, toxic ischemic hepatitis, we have very high levels of transaminases in the blood. Normal level of transaminases is up to 40-50 international units per liter, but here we may see 500, 1,000, and even several thousand units of transaminases in the blood. In case of chronic processes, because there is not very massive injury to hepatocytes, and also there are less hepatocytes than in healthy liver, transaminase level is elevated moderately. A summary of enzyme patterns is given here. If there is cholestatic problem, alkaline phosphatase and gamma-glutamyl transferase elevation is predominant, and markers of cytolysis, AST and ALT, are elevated slightly. And vice versa, if we have a problem with hepatocytes, we have high levels of AST and ALT and mild elevation of cholestatic markers. In case of alcoholic liver disease, we have interesting pattern of elevation that alkaline phosphatase is normal, but GGT is elevated. This is due to specific action of alcohol on this enzyme. Now about mechanism of hyponatremia in liver cirrhosis. Liver cirrhosis is characterized by accumulation of vasodilators in the body because they are not destroyed by injured liver, by fibrotic liver. They are accumulated and they cause splanchnic vasodilation. It leads to decreased blood pressure, and to compensate low blood pressure, antidiuretic hormone is produced. It somehow causes vasoconstriction as much as possible to keep pressure, but also it reabsorbs water and it leads to dilutional hyponatremia. So level of hyponatremia shows how advanced is liver failure. But also hyponatremia is a precipitating factor of liver encephalopathy. Let's recall that ammonia can penetrate to brain and astrocytes neutralize it by converting to glutamine. But unfortunately, glutamine is osmotically active and it elevates intracellular osmotic pressure and leads to water inflow. And this is why if we have hyponatremia, water inflow will be even more prominent, which will lead to astrocyte swelling and will provocate encephalopathy. An abdominal paracentesis was performed to check ascitic fluid, and serum ascites albumin gradient was counted in our patient, which reflects mechanism of ascites. If ascites is due to imbalance between hydrostatic and oncotic pressures, that hydrostatic is elevated and oncotic or colloid osmotic pressure is decreased. So there is transudation of fluid and there is very low albumin level in transudate. And if the leading mechanism is increased vascular permeability, this fluid is albumin rich. So if gradient is high, here we have low albumin level, and when we distract from albumin of serum, we get high gradient. It means we must think about disorder which causes increased hydrostatic pressure. It may be cirrhosis, it may be obstruction of hepatic veins like in Budd-Chiari syndrome, or right-sided heart failure. But if we have low serum ascitic albumin gradient, we must think about increased permeability. If gradient is less than 1.1, it may be biliary ascites or acute pancreatitis, tuberculosis, or spreading of cancer in peritoneum, which leads to increased vascular permeability and protein leakage. Here is SAAG of our patient. Let's recall that his albumin, serum albumin was 2.6 gram per deciliter, and albumin in ascitic fluid is 1.3, so SAAG is 1.3, which fits to transudate. Coming back to the story of our patient, we remember that it is his liver disease is related to alcohol abuse. So first, what must be done by him is to stop drinking alcohol. Every time when it is possible to act on the etiology of cirrhosis, we must do it. Maybe this is hepatitis C, so we may prescribe antiviral drugs. If this is alcohol abuse patient, we must encourage patient to stop drinking. We must care about nutrition and additional vitamin supply. And we must start treatment of complications of ascites, cirrhosis, ascites treatment, low sodium diet, and anti-mineralocorticoid drug spironolactone diuretic, which will help to remove excess sodium and water. And we must be careful with weight loss because excessive weight loss may provocate hypovolemia, which is risk factor of liver encephalopathy, together with hyponatremia. Propranolol can be used to reduce portal hypertension and prevent progression of esophageal varices, because bleeding from esophageal varices is very dangerous. Remember that patient has coagulation problems, decreased production of clotting factors, low platelet level, and bleeding from varices also may provocate liver encephalopathy, so we must manage this process of progression of varices. How propranolol will help him? This is non-selective beta blocker, so it blocks beta-1 adrenoreceptors in the heart and decreases cardiac output and decreases hyperdynamic circulation, one of the components of portal hypertension. Together with it, beta-2 adrenoreceptors are blocked, which will decrease level of splanchnic vasodilation and also will decrease portal hypertension. And next complication, what we must try to prevent, this is liver encephalopathy. And so, which are the precipitating factors of liver encephalopathy? Nitrogen products, more ammonia, more risk of encephalopathy. Ammonia may be produced from blood when it gets to intestines and metabolized by bacteria, ammonia is released. H. pylori infection, as you know, through urease, this bacteria can produce urea. If patient has constipation, all toxins stay at the intestines longer. Hyperazotemia and uremia, if it is impossible to excrete nitrogen waste products. This is group of nitrogen-related precipitating factors. Second group includes all metabolic alterations, alterations in electrolytes, in the volume of blood, and in acid-base balance. So let's say that every disturbance in electrolyte level, it may be hypokalemia or hyperkalemia, hyponatremia or vice versa, they may provocate encephalopathy. For example, if we prescribe thiazide diuretics or furosemide to treat ascites, we may provocate hypokalemia. And in case of hypokalemia, alkalosis happens and more ammonia is present in the blood. Ammonium ions are converted to ammonia in alkalic environment, and ammonia penetrates to brain easily. Drugs which suppress activity of neurons and exacerbate disbalance of neurotransmitters may precipitate liver encephalopathy. So these drugs are even contraindicated if patient has liver cirrhosis. And we have discussed prescription of diuretics. And let's discuss also infections. Every infection, it means a lot of bacteria, a lot of toxins. And one infection is especially dangerous. This is spontan bacterial peritonitis. Spontan, it means that there was no surgical process in the peritoneum like acute appendicitis, acute cholecystitis, but bacteria penetrate to ascitic fluid from the blood. Especially in case of liver cirrhosis, macrophages of the liver Kupffer cells, they can't bind and eliminate bacteria which are absorbed from gastrointestinal system. And these bacteria may penetrate to ascitic fluid and cause spontan bacterial peritonitis. It may lead to liver encephalopathy, and even prescription of antibiotics may not save the life of our patient. Well, so let's summarize. If our patient is compliant with prescribed treatment, it will stop progression of his liver disease and will help to control complications. This is what we must do and how we must work with our patient. So thank you for your attention. I hope it was interesting and helpful. Bye.